Hi, everyone, and welcome to this special interview where we are celebrating a remarkable achievement in the field of limb salvage technology. Today, we are thrilled to announce the winner of the prestigious Vascular Renaissance Award presented by the Global P.A.D. Associations as part of the Global P.A.D. Impact Awards. This award honors groundbreaking advancements in limb salvage technology, specifically recognizing the revolutionary impact of the Limflow system in restoring blood flow to critical limb ischemia patients. The criteria for this award, and there are quite a few of them that they had to meet in order to win this award, they include innovative technology development, clinical impact, proven clinical impact, research and evidence-based validation, advocacy and education, multidisciplinary collaboration, commitment to continuous improvement, which we expect in all technology. Everything is always evolving, right? Based on physician and patient feedback, as well as community and global impact, which we believe this technology is truly having. And we are honored to have Shon Chakrabarti, the Chief Medical Officer of Inari, which currently owns the Limflow system. And he is with us today to talk about the Limflow system, and he is here to accept the award on behalf of the entire team. Welcome. Thank you so much, Doctor. We really appreciate you being here.
Oh, thank you, Kim. On behalf of not just the current Limflow organization, but also a lot of the legacy Limflow folks that really helped conceive, innovate, and execute the clinical studies to get us where we are today. Delighted to accept the Vascular Renaissance Award from such a meaningful group of people. So big note of gratitude. Thank you.
Yeah, we are all about patient outcomes. You know that there's no other organization that has awards that really includes, the patient's voice. And the patient's voice was loud and clear in this one. So we really appreciate what you've been doing, with this system. I know that there have been doctors that have been doing these what we call deep vein arterializations, which we're going to get to in just a moment to go into detail for those who are just joining in and have never heard of the lymph flow system and they don't understand, what it's having an impact on or what it does. But, there are doctors that pull some tools off the shelves and have been doing that. But what I really like about what you've been doing is you've really commercialized it and you've brought it into the mainstream where there may have been doctors that, didn't have any tools or any experience going that extra mile for these patients that have what we call this desert foot, where there's just no blood flow at all, getting through the foot to a potential wound that is on their toes or other aspects of their foot that won't heal. And because of that, their limb is threatened. They're on deck for amputation. And in comes a device that these doctors are now able to use in order to restore blood flow. And it's really amazing that you've been able to convert a lot of these doctors that never even treated a foot before that, who are now treating and able to save more limbs. And so for that, it's pretty incredible the impact that you've been having. So with that being said, I will stop talking. I want to get back to you to actually talk about what is the Limflow technology and what sparked its development.
Thanks, Kim. I think you set up really well the why. We currently live in a time where there's over 500,000 CLTI patients per year incident in the US. 150,000 patients get amputations. None of these statistics are lost on you, which results in almost an amputation every 2 minutes. And as you noted, our current options for these patients are somewhat limited. A good bypass is a great thing for an ischemic foot and healing wounds, but to be a candidate for bypass, you have to have a target, you have to have conduit, right? So a lot of patients simply aren't candidates for that particular solution. We've made strides in endovascular therapy, and I know you've been at the forefront of a lot of this, right? Atherectomy, balloon angioplasty. We now even have drug reabsorbable scaffolds that can be used below the knee. But for a large proportion of these patients, so maybe 10 to 20% of CLTI patients in total, all of those options are not available. mainly due to anatomical reasons, as you described, right? Patients don't have any viable inline flow to the foot. They have small artery disease in the foot. They have calcification, such that even if you were to do ballooning or angioplasty, you simply wouldn't be able to provide the perfusion, the blood flow needed to heal those wounds. So that's the why. That's where the genesis of this purpose-built technology comes in. Um, and the idea of deep venous arterialization. So essentially, we have perfectly good veins in our foot that don't suffer from a lot of the things that we just discussed, small artery disease, calcification. These veins drain blood from the foot. But what if instead of these veins draining blood, these veins provided blood to the foot? And that's the whole concept between deep venous arterialization. And what Limflow has done is create a purpose-built toolkit. And I have to tell you, obviously, Limflow was recently acquired by Inari. Inari very much specializes in this very concept, purpose-built technologies. It's amazing what purpose-built technology can do when it's applied to a specific purpose. So this technology targets those 10 to 20% of CLTI patients that have no endovascular surgical option and allows an operator completely endovascularly, so no open surgery whatsoever, to
Right.
use
It's
two
just through a
access.
keyhole. So we call them, the keyhole procedures where they
Yes,
go in and it's just the size of a little keyhole that they can send in wires and catheters and balloons and stents and even some rotor-rooting devices in order to restore blood flow.
you got it. Yes, keyhole procedure, one access in the artery near the groin, one access in the bottom of the foot in a tiny little vein. And using our toolkit, which has 4 components, you can cross from the artery into the vein right below the knee, and then create a pathway from that crossover down to the foot, utilizing the veins to provide oxygenated blood to the foot, essentially reversing flow and reimagining the anatomy of how we provide blood to that foot. And the really interesting novel thing about this is it doesn't require those diseased calcified arteries in the foot any longer. You're now leveraging those somewhat healthy veins. There are many things that, you really need to make this work, which is why this technique before a purpose-built toolkit often didn't see the success we're seeing today. Veins have one-way valves, Kim, that make blood go up, back up to the heart. You have to obliterate those valves so that blood can flow downward. And then importantly, we leave a stent graft, so a covered stent that goes from the artery into the venous system down to the foot. And this keeps the blood from going into all sorts of other branches, and directs the blood directly down towards the toes, because that's where these wounds are, right, Kim? They're in the toes, the metatarsals, the forefoot. So getting oxygenated blood to that territory is really the goal of the procedure. This is done anywhere between 90 to 120 minutes, as I mentioned, completely endovascular therapy. And we've seen remarkable results in terms of wound healing over the course of the journey here of the PROMISE studies and the Limflow technology.
Now, in listening to this, I'm absolutely certain that quite a few patients are going to say, whoa, wait a minute. So our bodies were designed in the way they were with a vein that needs to be, sending that blood flow back to the heart. What happens when you hijack one of these veins? Do you have less blood flow to the heart? Now, I mean, we know the answer, but I just want you to elaborate a little bit on that so patients understand, the venous system and that
Yes.
we have so many veins that are connecting and bringing blood flow back.
Yes, Kim, you nailed it. And I got to tell you, I've learned a lot about veins since jumping into this world. And I'm an interventional cardiologist. I'm an artery guy, right? I'm used to dealing with arteries and opening arteries and providing blood flow. So the ways our body are designed is to really have a lot of redundancy in terms of draining blood from our organs and getting them back to the heart. Veins in particular are typically paired. So interestingly, we have tibial arteries. We have 3 of them below the knee. But we have paired veins, so 2 veins per artery. This is really useful because you've probably heard of people getting blood clots in their veins. And even when that happens, we can typically still drain and get blood back to the heart because of that paired nature. In addition to having paired veins, we have both the superficial and deep system. So we have veins that drain the tissue near our skin and near the surface of the body. And then we have deep veins that drain tissue that's deeper in the body. But these are interconnected with little things called perforators. And so when one system goes out, there is sort of a lot of backup there. which really allows us to leverage the venous system now to move blood forward into the foot while not losing the ability to drain the foot, and have that blood flow sort of continue in a circulatory pattern.
Now, this is something that we tell patients that with every procedure, it's not a permanent solution. That even with this particular system, it's specifically designed to get just enough blood flow to the wound to try to heal the wound and get that patient up and walking, right? To grow the collateral network of vessels again. And we always, in our network, we talk about growing those collateral vessels and the importance of a patient being a true partner in their care and not being reliant on procedure after procedure.
Yeah, it's an excellent point, Kim. What we're doing is redoing some plumbing, right? We're creating a conduit to provide blood flow to tissue that needs it. But there's so much more that has to happen for these durable results and for complete wound healing, which we've seen, by the way. We've seen remarkable numbers in terms of healed and healing wounds throughout the PROMISE studies. What does that take? It takes all the things that you need independent of redoing this plumbing. It takes really great wound care and partnership with the interventionalist and the wound care provider to make sure that the circuit's providing what's needed. And if it isn't, sometimes these circuits need a little revision to do so. It takes medical therapy, you got to be on the right medicines to promote healing, to keep your other factors in your body under control, right? Things like your blood pressure, your cholesterol, etc., your blood sugar, and really regular follow-up. But I'll tell you, it's remarkable when this circuit that you create, this redone anatomy does its job, then you're exactly right. New blood vessels grow and remodel to actually provide blood to this tissue. Now, we've seen really good, what we call patency. We've seen really good results in terms of these grafts staying open, mainly due to that purpose-built design. But I'll tell you, after 3 to 6 months, once these wounds have been healed, there is durability. There is sort of this neovascularization that potentially can provide a lasting result as long as those other factors are taken care of.
And what are the indications for a patient being the right candidate for the use of this technology?
Yeah, great question. So, our FDA approval and our label really speaks to any chronic limb ischemia patient who does not have surgical and endovascular options available to them. So that's pretty broad, right? And it defines a lot of different anatomies. It defines a lot of different wound locations and wound types. But if a patient is facing amputation, and it's due to a blood flow problem, and the patient has been told that we can't offer you any more surgeries or stent procedures to prevent this amputation, well, that sounds to me like a Limflow patient.
Does it matter, which vessel, like the perineal or posterior tibial or anterior tibial that you're connecting from?
Oh, now you're speaking my language. So
Those are the three. So for those are the three vessels in the calf that are feeding.
Yes,
And so I'm
yes.
curious because I've never asked this before, and I was just thinking about it, going, well, we just had a patient that, and they always say, if you have the perineal and it's going down, it's connecting, like the patient could be really good. So,
Yes.
but I'm curious from the other two vessels as well. I mean, does it connect from any vessel
Yeah.
that potentially feeds the foot?
I love that question. So look, you mentioned three tibial arteries, the anterior tibial, posterior tibial, perineal. The anterior tibial really runs to the front of our foot, the dorsum of our foot, right? The perineal, kind of the middle, if you will, and the posterior tibial comes down around the heel and provides blood to the bottom surface of the foot. Now, all of these connect, as you've noted. We've seen the most success, Kim, with a posterior tibial artery to posterior tibial vein connection. That's been the majority of the procedures that have been done, over 75% of the PROMISE study patients, and I would say even a higher proportion since our commercial release. However, that's not to say that you can't leverage either the perineal artery to perineal vein or perineal artery to posterior tibial vein or anterior tibial artery to anterior tibial vein. All of those are doable. But what we've seen in terms of the most robust result has been patients that do have that more favorable posterior tibial anatomy. And keep in mind, arteries that we're leveraging as donors, if you will, to provide blood over to the venous side, the connection that we're making, are often occluded at the mid calf. And this can actually even be favorable for our procedure in terms of preventing a steal from blood flow that otherwise would be getting to the foot. But to answer your question, we can use any of them, but PT is our most common and most successful.
How high up can you actually connect over?
Yeah. So as you know, there's a trifurcation of these vessels below the knee. First to an anterior comes off, then a posterior perineal tibial trunk, which
Mhm.
then gives the perineal and the posterior tibial. Let's use the PT as an example. If you're using the PT as a donor, you really want to get a couple centimeters below where it splits from the perineal so that you're not sacrificing any flow to those other vessels. Ideally, you get a centimeter or two down and then you do the crossover. That's still pretty high up in the leg, right?
I was gonna say, I mean, the way I imagined it was, and I had seen a couple done, was further down the ankle.
Yeah. So
So
the
this
nice thing
is
about the Limflow
incredible.
system is that we are stent grafts. Usually we use between 2 and 3 stent grafts total to create that connection from the crossover point down to the ankle. And this can be, some of these stents are quite long, 150 millimeters in length, 60 for our crossover stent, and you can use up to 3 of them or more in a procedure. So you can create this longer conduit. You get more blood flow the higher up you are, as opposed to being lower. And you really block off all those other branches and eliminate, Kim, the opportunity for all that diseased artery that comes before the crossover point to ultimately end up shutting down the graft. So we actually think that the novel Limflow procedure, that's one of the reasons mechanistically that it has seen superior patency rates and superior clinical outcomes when compared to other ways that deep venous arterialization has been attempted in the past.
So can you go through some of the clinical studies, the results from them, such as the PROMISE trial?
Yeah, absolutely. Happy to. So, the first PROMISE study was an early feasibility study that sort of helped lead to the pivotal trial, which was called PROMISE 2. Perhaps I'll focus on PROMISE 2 because it's the biggest one. So this study was at 20 U.S. centers, 105 total patients, a prospective study.
That's a
Uh,
lot. How many years?
yes, it enrolled
That's
over.
a big study.
It is, and you know how frequently these patients present, right? So to do that in 20 centers was pretty remarkable.
Mhm.
This study was, as I mentioned, prospective and core lab adjudicated. So we had an independent review committee establish that yes, this is a no option patient that meets the inclusion exclusion criteria of the trial, and then all of the endpoints were adjudicated by a core lab, an independent party. The main endpoint we're looking at was amputation-free survival for these patients at
Yeah.
6 months. So what does that mean? It means that at the 6 month mark, you're both alive and you've kept the leg in question. So if you either didn't survive or had an amputation, you would fall out for that endpoint. To give you some background, we also sponsored a natural history study called Clarity, where we looked at this relatively same group of patients at similar centers in the US prospectively that didn't get lymphotherapy, that got medical therapy, or in some cases, off the shelf or off label DVA. So, to frame this, in that Clarity study, amputation free survival was only 38% at six
Mhm.
months, meaning less than 4 out of these 10 patients were alive and kept their legs only at the 6 month mark, which gives you an idea of how close these patients really are to amputation when they present to the Limflow procedure. Now, remarkably, in the PROMISE 2 study, the amputation-free survival rate, that same metric at 6 months, was 66%. So now nearly 7 out of 10 not only survived but kept their leg. And you know as well as I do, Kim, that survival is intrinsically linked to amputation, right?
Mhm.
If you keep your leg, you're much more likely to do all the healthy things that help you stay alive and have high quality of life. When you think about just limb salvage, so did they receive an amputation or not? Freedom from amputation or limb preservation, if you will, was 76% in the Promise 2 study. Again, quite remarkable because all of these patients otherwise are facing amputation.
And we're
You know,
talking literally no, are we talking major amputation, above the ankle, or are we talking, because I
right.
know quite a few patients where they end up with the TADV and or the deep vein arterialization, and they still need to lose a toe. What your
Yes,
goal is, you might end up with a transmetatarsal amputation, losing all your toes or even a toe, but the goal is really reducing the major amputations, right? When it comes to this technology. I mean, any
absolutely.
amputation you want to prevent, but when it comes to this, usually patients are really at that point where they're going to lose their leg.
Yes, yeah, absolutely. A lot of these patients who have tried other interventions and are left with no further options already have necrotic gangrenous toes, and those minor amputations, if you will, are part of the therapeutic process to save the leg. So it's an excellent point you bring up. The statistics that I just cited are for major amputation, meaning below the knee amputations, or in some cases above the knee amputations. Minor amputations, so as you mentioned, toe or metatarsals, are very much potentially part of the treatment process, and even something that promotes healing and ultimately saves the leg long term. We did have some patients in the study preserve toes because their wounds weren't so far along that this blood flow was able to also save toes. But when we talk about freedom from amputation, we're really anchoring to that major amputation metric. And I've gotten a lot of education, Kim, from my podiatry colleagues on just how much it improves quality of life to be able to keep most of your foot, as opposed to going further up, Lis Frank, Chopart, or even BKAs.
I love the fact that you said that there are some of these patients that were able to keep all of their piggies. And I think that that's where I'm really excited to even, potential do more with your organization, going forward, because I think it's really important that patients understand. What we hear from so many patients is that I'm really ashamed of what my toe looks like. And they won't, it's one thing they don't want to show their family, but it's another thing when they're so ashamed, and we hear this, it's a reality. And you might wonder how, but it is a reality that they're so ashamed that they don't even want to show their doctor. We had a doctor on the other day who this wonderful little lady, comes in, 87 years old, and she says to the doctor, I haven't shown this to anyone. I'm really
Mhm,
embarrassed.
mhm.
But I'm showing it to you because it really hurts. And I'm
Yes.
wondering if you have a pill for it. And the doctor says, oh my gosh, yeah, that you need blood flow restored. I mean, this is crazy. So we need to get patients to not be ashamed about this and recognize that something can be done, especially if it's sooner rather than later. You might wonder, how do patients even get that far with where a wound develops? And there are a lot of reasons for that, even. It could be masked by so many reasons. You might have had symptoms of leg pain, leg cramps, neuropathy, whatever, brushed off. The fact is, when you do have that wound, you got to get to the doctor soonest. There
Hmm.
are options available. And at the Global P.A.D. Association and our Leg Saver hotline, we know those doctors that are performing this type of procedure or have the capabilities. All I do is I give a call to the doctor here and I say, hey, who do you have in this area? But and you have someone that has every single option for you to exhaust all efforts to save that foot and even just that one toe, right? The
Yeah,
earlier the better.
yeah, very well said. The earlier that we can identify folks that have this issue of ischemia, of decreased blood flow down to the foot that could ultimately lead to tissue loss, the more options that are available to them,
Yeah.
and I think you said it well. The list of comprehensive skills that an excellent operator has to help these patients now very much, I believe, includes, TADV, includes the Limflow technology, in addition to the other things that, geez, if you can get to them earlier and provide these more simple options, or more, or in some cases, very durable options, that's great. But But I think your collaborators, Kim, the folks that you're able to connect patients to, I think more and more of them are going to be adding this to their armamentarium, and I'm really excited for that.
No, me too. We even have gotten calls from doctors who said, "Do you know someone that can train us? Who has it in my area? Who can I fly to teach me this?" And so that's pretty incredible. And what's even more interesting is, and this is why it's really important that we're doing this interview in the format and with the audience that we have, is we even have a comment on YouTube from Jay who says, "I have PAD, a white foot, no pulse in right foot." And this is something that he's on there right now, and now he knows that he's not going to settle for less than a physician that has the ability to perform a procedure like this if it's medically appropriate, if amputation is potentially on the line, that, hey, do you have this TADV procedure? Do you use Limflow? Or do you know someone who does? Are you willing to give up the patient to someone who does have it? Can you refer me to someone who does this procedure? And I love empowering the patients with this information, because I think that that's what the Susan G. Komen Foundation did when it came to breast cancer. And I think that's what made the difference, was really creating a groundswell of patients to say,
Mhm.
hey, I deserve an early detection. I deserve a test, which we need to do the same here with peripheral artery disease patients. So that's so important.
Yes, 100% agree. And what a great question that you received. And you're absolutely right. I think why are we doing this? Why are we all in this
Yep.
fight together? It's for these patients. And what better way to serve patients than to empower them, right? With knowledge
Yep.
and with the tools they'll need to advocate for themselves. So I'm
So
100% a believer in that.
now, with every technology, I want to go back to the stories. You've been with this company for a very long time. I know I have followed a medical device maker around the world, introducing it, being a part of the training with it. I know it's not easy. I know you have to smile and grit your teeth in quite a few situations. There are a lot of naysayers, especially with something new, something different, and especially the direction that your organization decided to go, with hospitals in which doctors didn't have as much experience or willingness to treat the smaller vessels below the knee and into the foot. And we're very quick to amputation. And actually, just, I digress, but that's one of the considerations that we had, is we love the impact that you had on literally increasing the number of doctors willing to treat below the knee
Yes.
and into the
Yes.
foot. So kudos to you guys for doing that. But anyway, going back to really, my point in the whole, in this scenario, is, what sort of resistance did you face along the way? I can see a little smirk. There are stories that I know stand out. You don't have to name names. You don't even have to name the country or the state. But I'm curious about some of those conversations that just had you shaking your head, going, do you not realize, like, this is a big deal?
I think my response will be a bit high level and
Oh, we like
it-
specifics. Come on. That's no
even
fun. Oh,
even
I'll
even
tell you stories if you tell me some too.
Kim, it's not even just this technology. Even in the VTE space and the chronic venous disease space and the mechanical circulatory space, a lot of spaces I've worked in the last several years, um, it's hard to create change, right? To really innovate, not just add a Me Too technology or not just add an offering that slightly improves on something that's already available to patients, but to actually disrupt the current patient pathway or the current treatment algorithms to add something new. This happens a lot in med tech and in innovation,
Mhm.
and so it's not a unique challenge in that sense, and Limflow certainly faced it. Um, and even now, I think that there's so much work to do in terms of um, telling the story of how patients benefit from this, but not only that, creating clinical evidence. And what I'm proud of, and what we'll continue to do, is really lean on good, objective, high quality clinical evidence to tell this story. And so that way, the early adopters, the innovators, they're already using Limflow. They're already using other NRE technologies, right? They've seen the results on
Yeah.
the table. They have the patient stories. That's sufficient. But we need to win over the late adopters, perhaps the more conservative operators. There's a role for that viewpoint. And the way we win them over is with this high quality clinical evidence and continued um, good results even in the commercial world. So save
Right, but
limbs.
you
That's how we
need
address it.
people to buy, you need doctors to actually help create the evidence. And what always seems so frustrating to me is I would sit there and I would observe the conversations between the medical device maker and the doctors. The doctors say, "Well, show me the evidence," and then the medical device maker is like, "Well, why don't you be a part of creating that evidence?" I mean, we need doctors that can actually be a part of it. So it's always frustrating to me when even I have doctors that say to me, "Well, show me the evidence." Well, aren't you a practitioner? Isn't part of being a doctor practicing medicine? So doctors need to practice medicine. They need to be a part of creating the evidence versus resting on their laurels and resting upon other people to do it. We all, especially when it comes to the treatment of PAD, because we have so much further to still go. We don't have a cure yet. We don't have the Holy Grail. We have a Hail Mary, but we don't have the Holy Grail. We're getting there. Um, right? You like the way I phrase that. But we need doctors, all hands on deck to work in partnership with companies like yours to continue to develop these technologies to help improve the quality of life for these patients with PAD.
I think that's very well said. It is a partnership. Every physician that I've interacted with has actually been remarkably and refreshingly um, forward thinking in terms of this particular patient population. And part of that, Kim, one thing we benefit from at Limflow is that we're primarily dealing with no option patients. The other technologies that I've been involved with, it's a bit of a harder sell at times when you're trying to create comparative effectiveness versus other options. Here, I mean, what are you relegated to if you have no more surgery or intervention options, right? It's wound care and medical therapy up until the point you lose your leg. So I think that has really created a groundswell, and I have to tell you, the physician community has really been has been supportive, and also lots of interest in terms of generating new evidence. A lot of the folks, Kim, you and I were recently at the amputation prevention meeting in Chicago, and I'll tell you the number of hallway and happy hour conversations that I had with doctors with novel ideas for evidence generation in this space. Pretty remarkable. So I'm optimistic.
How many conversations did you have along the journey, especially in the early days, where the doctor would say, "Well, why delay the inevitable?" And you would say, "Well, what do we have to lose?"
Yeah, I think we still have those conversations. You know, I think a lot of the folks that were involved with Limflow from the early days had a lot of those tough conversations, but we're able to find innovators um, to really think about novel solutions here. And today I'll tell you, there's a recognition for just how serious this disease state is, right? What CLTI means to patients once they've gotten to that point on the PAD spectrum that they qualify, if you will, as a CLI, CLTI patient. That's a very specific group of people. And I think we're committed, and a lot of physicians I talked to today are committed to getting the right resources in place to help these folks.
Yeah, no, that's amazing. We have Douglas that wanted to jump in. He's in our live studio audience. Douglas, you have a question.
Yes, sir. Thank you. This is fascinating to listen to. And I was wondering, how far do you think the technology can go with it from here in what you've learned and what you're learning now?
Thanks, Douglas. That's a really excellent question. I think the sky's the limit, my friend. We have some of the smartest right downstairs from where I'm sitting now, engineers that I've ever met working on innovating this toolkit. And how do we innovate it? We make it easier to use. We make it usable in more patients. We make it even more durable. There may be a world where even before developing a wound, something like Limflow or an adjacent technology could keep a patient from getting to the point where they develop a threatened limb. So I really do think the sky's the limit. How far we've come from where this started to where we are now is already remarkable. And you heard some of the statistics around limbs saved. Um, as you probably noted, more and more of medical device technology is focused on making things smaller, faster, safer. And I very much can tell you that at Limflow we're exploring all of that direction. So I think it's really exciting. I mentioned at the beginning of our interview the scope of patients that we're currently treating, but based on where this goes, it really could expand.
But how do you maintain really that edge that you have right now? I just heard actually for the first time at AMP that there are now some Me Too's that are coming out, and you're first to market. How do you maintain that edge?
Well, first, I surround myself with people that are way smarter than me, like you. So that's the easy part, right? I don't actually see this as a terribly competitive landscape in the sense that, I've always been someone that thinks we should welcome new innovation, right? And you've mentioned, I guess, a head start is a way to characterize it, but bringing a product to market, a PMA product for FDA approval and everything that goes with it, the feasibility studies, the pivotal studies, it's not a short pathway. Um, and we're already iterating, Kim. We're already looking at a new stent delivery system. We're looking at upgrading the other components. So we have several development projects that I think will keep us innovating and doing the things that Douglas asked about. And I would say the more technology companies and more people that want to get involved in helping CLTI patients, the better. And I think we'll see different flavors of solutions. We'll see adjunctive solutions. And I think there's more than enough room here, Kim, to help these patients for all of these innovators.
I really like that attitude because there is no one size fit all when it comes to the presentation of peripheral artery disease and critical limb ischemia, especially. Everyone seems to present, somewhat differently, and it could be the difference between one technology versus another. And even though maybe both technologies work, maybe either one might just have a little bit more of an edge. And two, maybe a doctor is more comfortable with whatever skill set that they have, whatever technique that they use, even from the point of which way that and how many fingers that they want to use to twist the wire, whatever it might be. There should be multiple options to go around, but no, you do have a head start and they don't know what's in your pipeline. So it's good to hear. I'm curious, based on those trials that you had, the recent trials, how did your technology evolve once you ended up with the FDA clearance based on what you learned? Because you got to keep maintain until you get that FDA clearance, right?
Yeah.
Then how did you evolve based on the feedback that you received during those trials?
Yeah, the toolkit has really evolved quite a bit since the early days. I'll give you some concrete examples. They're a little bit technical, but I think they're cool. The crossover part of the procedure, where you actually poke from the artery into the vein and create a conduit. This is all done inside the leg, right? This is not open surgery. So it needs to be visualized somehow, not with your naked eye. The original toolkit, Kim, actually just utilized ultrasound technology. So we literally put a probe on the leg and had components that were visible and would allow for that crossover. We quickly learned that, this is more technically successful and faster if we use fluoroscopic techniques, X-ray techniques. So then components were made, the V-Seaver and the arc catheter that are opaque on X-ray and have specific directional elements to them that allow you to, in a 2D plane, know exactly where you are using a couple orthogonal views and do that crossover now under X-ray, previously done under ultrasound, significantly improves our technical success and our procedure times. I mentioned stent delivery. So, one of the critical parts of this procedure is precisely laying down these stent grafts so that these patients have a viable circuit with appropriate blood flow. So as you know, in the stent world, the more precise you can be and the better the delivery system, the better the result. And so we are have just had FDA approval and are moving towards market release of our updated stent delivery system, which is going to be much more ergonomic. And again, I expect to improve both technical success and procedure time. So you can't rest on your laurels. You need to constantly be improving and innovating. And so that's very much the approach we've taken.
And one of the things that's missing from this interview, I want to hear, because you're really passionate and motivated, with this technology to keep evolving it and to save life and limb. And I'm curious, you've been in quite a few of these procedures, you've talked to patients. Take us, tell us about a patient that truly, every time you're looking at a new iteration, anytime you're going to work, maybe you're having a bad day, maybe things aren't working out, you always think of that one person. Tell us that story.
Yeah, that's a really good question. And we, Kim, one thing we do here at Inari and at Limflow is town halls. Every quarter or so we get all the employees together, and one component of that town hall is a patient story. And the last one we did, we actually highlighted a Limflow patient, and this is the sort of thing I think about when I think about the why if we do this. So this patient, and I'll code the name, but we'll call him John. Had received multiple consultations that told him that he had no option and would need to lose his leg. One of those consultations was at a world-class institution, where you would expect every available therapy to be available, right? But he was told on multiple opinions, 3 separate physician visits actually, that he had no option to save his leg. He was able to connect with the Limflow team, who currently was at that time conducting the study, the PROMISE study, and was able to connect with one of our physicians and get a successful TADV procedure. And believe it or not, despite those 3 opinions, he still has his leg. Two years later, he remains healthy and active, playing piano, hanging out with his grandkids, taking walks. And I think that exemplifies the impact and sort of the dramatic impact, right? Going from 3 opinions, not one, to a endovascular, in and out of the hospital sort of procedure that results in that sort of impact on quality of life. And he's just one, Kim, of the many people that are represented in those PROMISE study results that I mentioned before. So, I mean, just imagine the impact going forward, right?
And it's so frustrating, for me to hear. I mean, he had to go through 3 different opinions, but he is, the exception to the rule when it comes to a lot of these patients. So many of our patients like and trust their doctor, and this is what actually really sucks. So they won't go get another opinion. They say, my doctor is at this large facility. They're famous. They have 5-star reviews online. Why wouldn't I believe them that amputation, it's the only option? Why would I go somewhere else? No, I don't want to lose my leg. But 1, I don't want my doctor to be mad at me. Number 2, everyone referred me. They all think he's great or she's great. And that's why I think it's so important. Number 1, we just tell every patient before any procedure, I don't care what it is, we have a consistent rule: always get a second opinion, even a third opinion. Your life and limb are truly worth it, right? But we want to empower them with this information so that when they do go searching online, that, they might like and trust their doctor. They might be searching about life after amputation, but they find this YouTube video that says, what if amputation isn't the only option? What if? And they hear about this new technology. You're only going to be rolling out across what? How many do you think you're going to hit over the course of the next year?
Yeah, do I think we'll be in every OR and cath lab in the country? No, but we're opening new accounts every day. And I mentioned the number of centers in PROMISE. I think we'll be well north of that as we continue this commercial launch.
And you're really trying to spread out. So at least hopefully we'll have, you know, these types of procedures, these Hail Mary procedures, you know, within a few hours of every single patient,
Yes.
at least across the United States. Hopefully, we haven't even talked about global, which I want to
Yes.
hear about
Yeah.
in a second. But my point being is, number one is empowering the patients with this information that it's no option, that there is probably another option, and inspire them to get that next opinion from someone who does know how to do a procedure like this. But number two, it's getting those doctors who don't perform this procedure to, one, want to, but if not, to refer the patient to someone who does the procedure. Tell the patient, hey, you know what? I don't do it. I don't have this technology, but you know what? Even if I don't know someone who does it, go online and find a doctor who does.
Mhm.
And if you can't find it, it doesn't work, I'm always here for you with this option of amputation.
Yeah, you know, I just saw a comment that from someone in our chat that sometimes it's just fear of how your doctor would react to you seeking
Yeah.
a second opinion. I have to tell you that my colleagues in interventional cardiology, interventional radiology, vascular surgery, general medicine, you'd be surprised um, by how open they are to patients advocating for themselves. I personally, Kim, was never offended when my patients sought a second opinion. If anything, it made me feel a lot safer in how I practice. We're all evolving, we're all learning best practices. We don't want to make mistakes because our mistakes have big consequences, right? So, what better way to validate the way that I'm practicing than for someone to seek an opinion? So I think that's a very healthy part of the process. Now, look, there are patients that simply won't be candidates for a number of reasons that we discussed earlier. Maybe they have a better option with surgery or bypass. Maybe they don't have anatomy or a wound status that would be amenable to healing with this procedure. But knowledge is everything, right? Knowledge is key. And I think a good relationship with your physician is also important. I think stigma and fear, the fear you even noted before, where you may not even want to take your shoe off and show it to anybody.
Yeah.
Those are probably the biggest barriers, much more so than hubris or attitudes amongst our practitioners.
And we tell a patient that if a doctor is not okay with you getting a second opinion, that's a red flag. Go get a second opinion. You know, that's really important. Just always, always, always go get one. But it's not. This isn't just a United States device. You're launching globally.
Correct. We're currently pursuing regulatory approvals to not only have the product approved, but also the devices we make approved outside the United States. You know, the original studies for the early Limflow devices were OUS. The ALP study, a lot of the original procedures done by Dr. Kum in Singapore are what shaped the current toolkit. Right now, we're FDA approved and are allowed to make product in the US. And what we're trying to do, Kim, is really do robust training and get great outcomes here so we can learn and iterate and prepare us for going global. And we already know we have great operators in Europe that have done a number of cases in the PROMISE studies. I would point you to PROMISE UK, which has been presented in abstract form and is now also published in the British Journal of Surgery, BJS. They actually were able to, in 28 patients, not quite as many as the PROMISE 2 study, achieve limb salvage of 81%. So even above what we saw in the PROMISE study, over 8 out of 10 patients either healed or completely healing. So there is great operators out there, and there are certainly patients. And so every intention to take this globally. Job one is really, as you noted, iterating, refining, learning about this technology here in our US launch and getting it right.
And you bring up a really good point that I always tell to my patients. Different doctors, different skill sets, even doctors that graduated from the same medical school, they can graduate at different, you know, levels of the class with very different skill sets. And so it's just because they have the title doesn't mean they have the best skill set. And I'm sure that that may be reflected actually in the studies that you have, that maybe, you know, different doctors, different skill sets that may affect how well the patients do following the procedure itself. I know you probably don't want to comment on that, but it's true. Not to say that anyone is a bad doctor that they're who has participated at all. It also could be something where just the timing of it, where things were learned from the early days clear up until now, or whenever the UK study was done, right? That you learned and grew together. And maybe the first doctors who used it didn't have the ultimate techniques that you have learned along the way now.
It's a great observation. There are secular effects just on based on when we learn, how medical care improves. In the case of the UK, Kim, I think there's also really well-established systems of care, diabetic foot clinics. It's really a system that doesn't lose the patients. And it's replicated in the US as well at some of the CLI centers of excellence that you've been a part of and have helped identify. Someone said it earlier on the chat. It really does take a village, physicians, patients, device companies, nurses, techs, vascular ultrasound. All of this is so critically important to the goal, which is saving lives.
I want to bring up one more point when it comes to that I think is really important when it comes to Limflow, and then I have three questions I ask every single doctor. And even though you're not practicing clinically right now, I would imagine that you would have some great tales to tell. But I think that this is really important when it comes to these procedures, or in fact, any procedures. You know, it took many years and a lot of work in a sense to get to the point where you are, you know, right now, if you are a patient that is on deck for amputation. And so you can't expect any procedure to just be the holy grail magic pill, and you don't have to do any work as a patient. With this particular technology, and I think actually any procedure, I'm just going to argue altogether, there's a lot of work that the patient needs to do in order to maintain their vessels open and to get back on their feet for good.
Yes.
And if you're going to say this is a tough discussion. If you're going to have this, you know, Hail Mary procedure, this Limflow procedure, the TADV procedure, where the doctor hijacks a vein and reroutes blood flow from the artery to the vein into the foot to perfuse the foot to heal your wound versus cutting it off, there's a lot of work that patient needs to put in to be the best partner in care. And so I would argue that not every patient is the right fit for a procedure like this, because it is going to take time and it's going to take a lot of effort, and you've got to be willing to put that time and effort in, right?
Yes, Kim. The Limflow has a very clear and stated goal. What we work towards is that any patient that would benefit from this technology is able to receive it. There's a lot that goes into that. One of it is education and sort of expectation setting up front when a patient receives this therapy. I don't see it that much differently, Kim, than a transplant or a VAD, where the only way this works is if the healthcare team and the patient have regular communication. The patient has an ability to reach the healthcare team if they see their wound going the wrong way or if they're experiencing new pain. Similarly, the patient has an obligation to go to follow-up appointments, take the appropriate medical therapy, do the supervised exercise regimen if that's what's prescribed. But most importantly, I think communicate. And that's really what it takes. It's while the procedure is technically very successful in almost every case, the ultimate result, which is saving your limb, still requires all of those adjunctive things. So I think you characterized that really well.
Yeah, we have so many people that come in and they say, well, I just expect so much from these procedures and I just expect it to be all over with. My foot is saved. Okay, great. And then suddenly after the procedure's done, like they have all these other priorities that prevent them from, making that wound care appointment or making their follow-up appointment with that vascular doctor. And you need to, when you go into these procedures, you as a patient needs to really think long and hard and say, you know what, am I willing to put in and the time and effort to make this a priority? Because you really, limb salvage is serious business. You need to make your health a priority. You need to make the follow-ups a priority and the care a priority and the dietary changes and the exercise and the smoking cessation. I mean, I didn't even ask you if doctors who are performing this for the most part are telling the patients, hey, we're not going to do this unless, I mean, you got to stop smoking or else this is literally this is a moot point. Like, why are we doing this?
It's a great point. It's a conversation I would certainly have with my patients, and I'm not minimizing what it takes to stop smoking, right? I'm very familiar with many years in the coronary space with what it takes to do that, but it's all part of that resource discussion that we talked about, just doing this technical procedure isn't enough. Having all those other pieces in place, including support for smoking cessation, counseling, social services, all those sorts of things are part and parcel to a successful, I believe, Limflow program.
Yep, I 100% agree. So some fun questions for you before I know we're right here at the top of the hour and I don't want to keep you much longer. If you don't mind, these are proving to be the favorite questions of every interview with a doctor.
Very good.
So I hope that you still, I would imagine, have answers to these, but we have a series called Journey to Diagnosis, and I want you to share a case that just had you scratching your head about how in the world this patient was not diagnosed sooner and what you wished would have happened differently with that patient. Or you could share a story of a patient whom you couldn't believe had all of these other procedures and wasn't even diagnosed with P.A.D, but should have been diagnosed with P.A.D because none of those procedures provided any relief. Now that they've been diagnosed with P.A.D, opening up the arteries has brought relief. And I'm sure you've talked to a lot of even Limflow patients that might have fit the bill with this one.
It's amazing how much coronary disease, heart disease, and peripheral artery disease run together. I guess rather than a specific example, when I ran a cardiology clinic, one rule I had for my MAs and my support staff was everyone gets their socks off that comes in. You can be coming in complaining about chest pain, fast heartbeats. You could just be coming in for a preventative visit. Hey, I want to talk about my cholesterol and how I can improve it. I'm looking at your feet. Because all of the risk factors, Kim, that as you know, that that portend heart disease, which is the most common diagnosis in our nation, are shared by peripheral artery disease, right? And while some people will shake off minor chest pain, for the most part, if you're having heavy chest pain, you're getting evaluated. It's amazing how claudicants or even chronic limb-threatening disease patients sometimes won't surface these sorts of issues with their physicians. So there are countless numbers of folks, Kim, that diagnosed with P.A.D when they were coming in to be evaluated for something else. And when you learn about smoking and the pain with walking, it's remarkable what you can do when you intervene earlier rather than later. So I hope that answers, at least to some extent, that question.
No, I think it actually does, because part of this is educating other clinicians and physicians, and even patients to say, it's to have that expectation that, you know what, you need to take your socks off. Physician, clinician, you need to tell the patients, take your socks off every single appointment. So I think that's great. Share a case with a big lesson for you and others. And this, I think you could do with a Limflow case. Describe the patient, the frustration with the case, and the lesson that you and others can learn from it or have learned from it. It could be a success. It could be a failure. We have had both. You could include a little bit of ingenuity in there as well. I'm sure a lot of learnings along the way, but if you have one case that provided some extra special learnings, that would be great.
Yeah. There's one I recently was able to attend with a really skilled and innovative physician where we had a battle of a case, really heavily calcified vessels, Kim, that we sometimes see with these patients that makes every step just a little harder, every device delivery, every needle throw, etc. But we're able to get a successful initial result. And this patient, before they got off the table, the operator had the acumen and wherewithal to interrogate the graft one last time before they finally got off the table. And we actually heard some diminished signals that made us think, you know what, maybe this graft is threatened and there's a little more fine-tuned work we need to do to make sure this is a durable result so the patient can keep their leg. And I'll tell you, a lot of folks at that stage would have said, we've been at this for a while, send them up to the ICU, to the floor, and we'll get an ultrasound down the road and maybe give some blood thinners and keep this thing open. Well, he went that extra mile and put the patient back on the table, re-got access, and sure enough, that graft had acutely gone down. And one simple additional intervention was all it took to get a durable result. And 3 days later, I received a recording of a beautiful pulsatile waveform in that foot. And it just goes to show, I think the lessons learned from that are the complexity of this, and the sort of grit and persistence it takes to make a difference, especially with a new technology, right? So I think that's very illustrative, you know, of this space and the innovators and the types of traits that lead to success.
One more question for you. That was a
Yes.
great case.
Thanks.
Share 6 minutes that mattered in your career. It has to be a defining moment, a catalyst for change, a spark that led you in a specific direction. It could be a conversation you had with others. It could have been a scene in a movie or a show or a documentary. It could have been a moment you witnessed something eye-opening. What was the most defining moment of your career?
Oh, that's a tough one, Kim. There's so many, right? I think it's sort of a multi-hit hypothesis. There are so many things you go through that shape who you want to be. I have to go way back because I think you, the folks on this call, we're all involved in this incredibly noble purpose, which is healthcare, right? Which is improving the health of our fellow people. You know, I did my initial med school rotations in downtown Detroit, which is quite a place to learn medicine, right? And I got to see firsthand just how acute disease can really get. And I had a few defining moments, particularly in the emergency room of 8 Mile of Sinai Grace, where I really got to see firsthand just how big the need is. And from that moment on, really felt like, wow, I need to devote the rest of my life to this purpose, to improving health, and specifically to some extent improving cardiovascular health. So in the spirit of the whole call today and P.A.D. awareness, you know, that was a watershed moment for me.
Fantastic. Thank you so much, Dr. Shon Chakrabarti. We really appreciate you being here. Congratulations again. Limflow, our Vascular Renaissance Award winner of the year of 2024 through the Global P.A.D. Impact Awards. Congratulations, big congratulations. Thank you for all you do to help save life a limb around the world.
Thank you, Kim. Quite an honor. Thank you so much.